of bariatric surgery. The most common ones would be the sleeve gastrectomy, the Roux-en-Y gastric bypass. This one with the really long name, it's like more complicated. They're basically just doing a lot more re-anastomosis and things like that. And then there's also gastric bands. We don't really do the gastric bands here anymore. They also often have more issues because, as you can imagine, the band can slip or it's a foreign body as well, so it's not as ideal. And sometimes we also have revision surgeries because we might need to revise one of these types of surgeries. So just going into these two, the gastric sleeve surgery is where they remove 80% of the stomach so that what you're left with is like the size of a banana or shape of a banana. And then that also decreases a lot of the hunger hormones because all of that is just cut away essentially. And because you have a smaller stomach, you'll feel fuller quicker and you'll eat less and you lose weight. And then the other one that's really common is the Roux-en-Y. They also cut off a big portion of the stomach, but they leave it in there and then they reconnect your small intestine directly up to the pouch that's left. So you will also have decreased hunger hormones, but you'll also have more like intentional malabsorption. So everything just passes through a lot quicker and you're really not absorbing the nutrients, and that also will cause a weight loss. So who qualifies for bariatric surgery? Those with a BMI over 40 with coexisting medical problems. And then a lot of these are the common problems that are caused by or worsened by obesity, as you can see here. And then another indication is those with a smaller BMI, so BMI about 35, but they have one or more serious obesity-related comorbidity. And ultimately, the point of these surgeries is that you want to treat the morbid obesity, and then that will help the related diseases as well. And the intention is also to prevent like future problems. So if you're like younger and you don't really want to have really severe debilitating problems when you're like 65, 70, then these could be a good option. And then ultimately it is to improve quality of life. And then all of these surgeries now are minimally invasive. So that's really nice because there's no more like big open incisions, just ports, robots, stuff like that. So this is the actual bariatric ERAS protocol that we have. So it's really a lot, and I'll just go through part by part. It's honestly pretty simple because I'm sure you guys already know a lot of this, but in pre-op holding, everyone is obviously NPO. Some surgeons do want them to carb load. So about 2 hours before the procedure, they might be drinking grape juice or Gatorade or just one of those like oral clear liquids that would give them hydration and sugar, but then it wouldn't make them not appropriate to get anesthesia and like not appropriate to have surgery. And then we no longer really want everyone to get a scopolamine patch. So this is like older. Nowadays, we give everyone a Prepotent, and a scopolamine patch does have some side effects that we don't really want for everybody. So that's like a plus or minus. And then we do want people to have Lovenox 40 sub-Q ordered. That's ordered by the surgeon, but like, please, if you don't see that, if you see there's heparin ordered, just like bring that up to somebody so we make sure that we have the right, prophylaxis medication. And then the document in my chart is something from the centricity days, so we don't care about that anymore. And then the reason why we don't want any oral medications like Tylenol or gabapentin or anything is because the minute after we intubate in the OR, we put an OG tube in, we suction everything out. So if we gave anything inside, it's not going to have its full effect anyway. And then there could be a concern that if you have a little bit of remnant of a tablet in there, it could interfere with the surgery because we're ultimately working on the stomach itself. And then we want to type in screen with confirmation. This is intra-op. I just wanted to give a brief overview because these are some things that you could potentially listen for in the PACU handoff. So we want to make sure we have great POMV prophylaxis. Everyone gets a Prepotent, Decadron, Zofran. That's honestly for like every surgery too. And then for some of these patients, they might get additional things. And a lot of times we might run a propofol infusion in the background or just do pure propofol for the anesthetic because that will decrease the nausea vomiting risk. And then you also will have some different methods for pain control. So the whole point is we want to minimize the amount of opioids we get, both intra-op and after surgery. So we, of course, give IV Tylenol. We sometimes give Toradol, and then sometimes the surgeons will place these regional tap blocks, which is just infiltrating local anesthetic. And I'll have a picture of that next slide. And then you'll also see that, we'll try to limit the opioids in the case. So this is what a tap block is. It's essentially putting in a local anesthetic in the abdominal area. Hopefully that is to give those nerves in that area where the incisions will be some numbing. This picture is a catheter actually, but I think it's kind of nice to see what the actual ultrasound will look like. And you can do them with or without an ultrasound, I suppose. I have seen surgeons just sometimes put a needle there and just kind of put local there and assume it's sort of a tap block. Or sometimes I've seen anesthesiologists do it with a ultrasound after the patient goes off to sleep. But essentially, this is like a good way to try to decrease the amount of opioids they might need. Hopefully, it has some lasting benefit when they're in PACU, so they're not in a ton of pain. And then this is just another one that I thought of nowadays that we use Precedex so often. That would be a good medication for the in-room anesthesia team to be giving so that that also helps with some pain control and it makes opioids work a little bit better. And that's also something that the PACU resident could be giving as well after the surgery if they're in a lot of pain and we want to minimize opioids. So, and I've like seen a couple of papers from other institutions where they actually put like clonidine or Precedex as part of their intraoperative recommendations for these gastric bypass surgeries or bariatric surgeries. So the PACU part. So this is a part of the anesthesia order set that is specifically for bariatric surgeries. It's underneath the usual analgesic order set, and it's called the low dose opioids one. And then the main important thing, the main difference about this order set is that the first line opioid is actually PO oxycodone instead of IV medications. So that is a little bit different. And yeah, essentially, we just want to make sure that they'll be able to tolerate PO and then they can get this oxycodone. And then we try to limit the fentanyl and Dilaudid that we give. Also, another big goal is early ambulation. So some papers say within 3 hours of surgery, they should be up and walking and really trying to get that bowel function back. Because as you can imagine, having all that surgery and all that trauma on your stomach, on your small intestines, it's just going to make it all have more inflammation and probably more difficulty to wake up. But it's like really important these patients don't get bowel obstructions and then have to go back to the OR or have like complications from that standpoint. And so another thing is if someone's dropping off a patient and they don't have oxycodone ordered, you can let the PACU resident know or just be like, hey, like, by the way, these patients usually get PO oxy and then just alert them of this because I'm honestly not sure if a lot of the residents know about this order set or necessarily know that this should be part of the bariatric surgery ones. There is like information on our end. We have these like room tips for how to do a lot of these surgeries, and this is explicitly mentioned on that. But if an anesthesia resident doesn't look at it or if a CRNA doesn't know about it, then maybe we don't order this on accident. So that's something for you guys that to like think about, and you can help us with that. So the summary of this protocol is that for pre-op, make sure they have Lominox, make sure that we're not giving any oral medications, and we have a type and screen. And then a couple of things to look out for when they're giving reporting PACU. And then in the PACU itself, PO oxy is the first line, and then limiting your opioids. And then if the patient didn't get Toradol in the handoff, you can maybe ask the surgeon, like, hey, can they have Toradol? Or are they actively like, no Toradol for this patient? Because if they can get Toradol, then that would be really helpful as well. So what are some complications of this? I wanted to include this slide because there are some early complications that could happen in PACU. Most of these are going to be more long-term, and maybe some of them will be like, you know, they're in the hospital the next day and they have this. But essentially, the most urgent ones are if there's any sort of immediate leak or bleeding. And I'm sure all the signs that you guys are familiar with would be present. Like they're in a lot of pain, they're tachycardic, they're hypotensive, they're diaphoretic, like something just seems wrong. So they could be having a leak where they did the incisions. They could obviously be having bleeding. The risk of having a DVT or a PE is honestly really quite low, 0.3 to 2.4%. And then things to help with that is that the anesthesia team will give Lominox sub-Q in the start of the procedure. And then the patients, hopefully they can start walking or ambulating really quickly after surgery. That will also help with that. And then there's a risk of post-op nausea and vomiting because we're working on the stomach itself. And then also we don't want these patients to be retching and potentially like putting a lot of pressure on these incisions and causing any sort of leaks or bleeding. So all of the medications we give, we're very cognizant of that. And then of course, you know, treating that well in PACU. GERD dysphagia, this is something that I feel like is more, if this patient came in already with having some of these issues, that could be another problem. but that's not necessarily like an immediate complication you would see in a person who didn't have this issue and gets the surgery. It really shouldn't be something that presents in PACU right away. And then just to highlight some longer term deficiencies, and this is more important if a patient had a history of a prior gastric bypass and now they need revision. So they've been living with some sort of bariatric surgery, modified stomach, modified intestines, and now they're here and they're getting some revision. So they may already have nutritional deficiencies. Thiamine is a really important one, calcium, iron, vitamin B12. And then some patients, if they have had a prior surgery, they might have already some stenosis or obstructions, strictures, or ulcers in any of the sites where they're sewing things back together. So these are some of the complications. These are my sources. Any questions? Very short. Yeah.
I think they give it to
Wait, what is it? Oh, the intro.
We used to give it for any GI.
What is that? I don't actually. Do you know what the name of it besides Entric?
Not for gastric surgery. We usually give that for like bigger yeah. But
Okay.
not necessarily for this because we're not giving any PO. So even if you guys give the
But then there's an IV and I mean, I'm just asking because we used to give it. And then now it's like oh
yeah.
so they changed it to a IV now.
Yeah.
Okay. I'm not sure what that one is.
Yeah.
Okay.
It's like to prevent LES some
Oh.
surgery, but the economy is more for national. We also give it in Beaumont. That's why I also asked. There's other hospitals we give in Ventura.
It also has restrictions on it, the patients already taking opioids at home. They're not supposed to have it. I don't remember all that behind it, but
So
no, it's just pharmacy of the real.
they probably take it out.
Yeah.
I gave it here before, but it's like.
I mean, we have given it, but not necessarily for the bariatric. Yeah, yeah. We do give it here in pre-op, but not for the bariatric. But the most important thing and why we wanted to have this topic is people have been emailing us about like people coming out of the surgeons coming out of the OR saying that we can't give any narcotics in PACU, which you can tell from this. We can. It's just the CRNA or anesthesia. They're going to order the low dose opioid. If the patient's not nauseous, then you can start with the oxy. But you guys all know what's the most common side effect that we see here. They're nauseous. So we can still give fentanyl. It's just a smaller amount that we can give. So that's not the correct information when someone says that they can't have any IV narcotic here. They can.
Yeah. Yeah, because they're trying to balance like not bowel obstruction, but then at our end, we're like, this patient is in a ton of pain, 10 out of 10 pain. They're not going to get out of PACU. Like, we're not getting to the floor. We're not ambulating. We're not doing the other important things that need to be done to actually prevent bowel obstruction. So, yeah, so that's a really good point. Please, like, I think no opioids at all would be. It's just, I don't know how that's.
I feel like it.
Yeah.
Any other questions about ERAS?
Like how long is the tap block?
Yeah, so that is great question. So some people are like, does it even work? I mean,
does it depend on who's doing it?
Yes, I think if you're doing it with ultrasound, you have better sense of where you're going. I would say that, okay, I almost feel like with the tap block, it's like if it works, great, like gold star, like extra on top. And if it doesn't work, then we can't really do much about it because the other thing is you can't repeat it because you've given them local anesthesia of a dose somewhere in the body. So you can't really just like redo these things because you might overdo the local anesthetic.
I want to say that when the anesthesia does the tap block, they generally work. When it's someone else that's just randomly injecting, It might not work.
Yeah.
So
Yeah.
maybe pay attention to who said they did that.
Yeah. I think in these cases, and I talked to some anesthesia attendings, I think in these cases the surgeon would always do them because it is like, so I don't know about that. I don't know. I guess you guys could keep track of it and see how many
Maybe
patients.
we should do a project.
Yeah, just be like, hey, like, are you feeling numbness there? Like it, yeah, it should last a couple hours is the answer. Like at least it should last them through the first hour of PACU,
Yeah.
you know.
I mean, I really think the number one problem when they come out is their like, and then they do have pain.
Mhm.
But just reviewing, we to do this, we reviewed like, I don't know, maybe 10 bariatric surgeries and like 8 of them were not. I think it's more at that point.
Yeah.
Are there any questions in the chat? I don't think so. That's great. Thank you.
Everybody.
Oh, I'll put the sign in link again. All right. Thanks everybody online. I just put the sign in link. I'll give you a second and then I'll end the meeting.